The following podcast is part of a certified educational activity titled Fine-Tuning the Selection and Sequencing of HER2-Targeting Therapies in HER2-Positive MBC with and without CNS Metastases, expert guidance on how to individualize therapy based on latest evidence, disease features, treatment characteristics, and patient needs and preferences. Access the entire activity and complete the post-test at peerview.com/ZPG860. Downloadable slides and practice aids are also available.
Hello, welcome to Fine-Tuning the Selection and Sequencing of HER2-Targeted Therapies in HER2-Positive Metastatic Breast Cancer with and without CNS Metastases. This is an expert guidance on how to individualize therapy based on latest evidence, disease features, treatment characteristics, and patient needs and preferences. My name is Sarah Hurwitz. I'm a medical oncologist, professor of medicine, and division head of the Hematology Oncology Division at the University of Washington, senior vice president of the Clinical Research Division at the Fred Hutchinson Cancer Center. I'm really pleased today to be accompanied by my colleagues, Dr. Carrie Anders and Dr. Vaishak Vinur. Dr. Anders, would you introduce yourself, please?
Thanks, Dr. Hurwitz. I'm very happy to be here. I am also a medical oncologist, professor of medicine in the Division of Medical Oncology here at Duke University. I'm currently the interim division chief of medical oncology and serve as the co-director for the Duke Center for Brain and Spine Metastasis. We'll pass over to Dr. Vinur.
Thank you. I'm Vaishak Vinur. I'm a medical oncologist as well and assistant professor of medicine and oncology. I am also a trained neuro-oncologist. I lead the brain and spine metastasis clinic here at Fred Hutch. I'm also the associate medical director for inpatient services.
Welcome to both of you. I think this is going to be a great interactive discussion today. So our goals for today are to equip our audience with knowledge about the latest evidence and recommendations to guide selection and sequencing of HER2-targeting therapies in metastatic breast cancer, including systemic approaches for brain metastases, and to enhance our audience's skills in integrating current therapies into individualized treatment plans of patients with HER2-positive metastatic breast cancer, either with or without brain metastases. Our first module is going to be laying the foundation for resilient care in HER2-positive metastatic breast cancer, looking at modern goals guiding sequential treatment and real-world insights. By way of background, it's important to acknowledge that HER2-targeted therapies have revolutionized the treatment, disease trajectory, and outcome of patients with HER2-positive metastatic breast cancer, now including those with active and stable brain metastases. Previously, patients experiencing brain metastases really only had local therapies such as surgery or radiation to treat them, but we're moving into an era more and more where systemic therapies are showing efficacy in this situation. There are a multitude of treatment options available and emerging, and it can be challenging to navigate how to select and sequence each of these different types of treatment modalities. The treatment of patients with HER2-positive metastatic breast cancer with brain metastases poses additional challenges, but there are new data and options that are challenging our long-standing role of only using local treatment as the default for patients experiencing brain metastases. We know that patients with HER2-positive metastatic breast cancer with brain metastases often lack the resources and information relating to their diagnosis, their treatment, their survivorship, and it's really critical that we provide them this type of information so that they can be informed partners as they're making treatment recommendations. I'm going to pass the mic over to Carrie right now to talk to us about HER2-positive breast cancer with brain metastases, because this is an area that is emerged as being very important and having an incidence that's a lot higher than I think we originally appreciated some 20 years ago. Carrie?
Thanks, Sarah. That was an excellent introduction. It is very true that brain metastases have really become part and parcel of our care for patients with HER2-positive breast cancer. And just to kind of think about this historically, you'll see here a pie chart, which really illustrates the histologies where we see brain metastasis as a common consequence of advanced cancer. Historically, we've really thought about lung cancer, breast cancer, and melanoma. But what we're really seeing more recently in the modern era, particularly with advances in systemic therapy, as you highlight, that really any solid tumor is metastasizing to the brain and spine. But specific to brain metastasis and sort of in this light, kind of medium blue color, you will see, interestingly, that the incidence of brain metastasis for breast cancer really hasn't changed, even dating back to the 1980s, despite the fantastic advances we've seen in subtype-specific care. Specific to the HER2-positive subtype of breast cancer, we are seeing at least 1 in 3 of our patients developing CNS metastasis as a late or even an earlier consequence of metastatic HER2-positive breast cancer. And that really leads us to more modern data with the real-world data from a U.S. Flatiron database. And this is really interesting because when we think about our patients in our practice, when do we need to be worried about brain metastasis? And you can see here in the highlighted red box, the patients with HER2-positive, hormone receptor-positive advanced breast cancer versus those with HER2-negative, HER2-positive breast cancer. And even in the first-line setting, 1 in 10 of our patients may have CNS metastasis as a site of distant disease. And you can see as you go through different lines of therapy, this incidence increases with a pretty significant jump between line 1 and 2 of therapy for those with hormone receptor-negative HER2-positive breast cancer. By the time patients are at 5th line or greater, we really are seeing at least 1 in 3 patients diagnosed with CNS metastasis. So very important that we understand our systemic therapy options to provide for our patients as they're moving through their lines of therapy.
In the past, we had looked at brain metastasis as a site which causes a lot of neurologic symptoms and deficits and need to be treated in every single context. But there has been a lot of work on what are the prognostic factors that we want to consider when we are approaching a patient with brain metastasis. One of the examples is this GPA, or Graded Prognostic Index. This study looked at key prognostic factors like the performance status, called the Karnofsky's performance status, very similar to ECOG performance status, age at diagnosis of brain metastasis, number of brain metastasis, extracranial disease control, and the subtype of breast cancer as important prognostic factors, giving us a better guide on what the systemic and local therapeutic strategies should be for patients with brain metastasis from HER2-positive breast cancer.
That's really helpful. I'm wondering, Vaishak, if you can talk to me a little bit about how clinically you use prognostic scores or indices like this when you have a patient with you. Is this something that you do with the patient in sort of a patient-facing manner, or is it a little bit more subtle and nuanced than that?
That's an excellent question. I think generally it is more nuanced than these factors generally are reported as. As you can see, this is data from the last decade to up to 2020, and a lot of our systemic therapies are, novel systemic therapeutic agents are being developed since 2020 through 2024. So these prognostic indices often lag in terms of capturing all those nuances, but often can give us a framework to work on. For example, if patients really have poor overall performance status, doing things like whole brain radiation to add to the toxicity might be detrimental to their quality of life. So knowing what these factors are important, but there are all these online modules where you can put in these factors and gives us the number for prognosis or the range for prognosis. They may not reflect our current understanding of where we are in terms of management of these patients. So that it needs to be used in caution, but gives us a good framework for factors that we want to consider when we are making therapeutic decisions.
Yeah, I agree completely. I think this sort of information informs the direction and the guidance we provide to our patients. Carrie, can you talk a little bit about patient shared decision making and how you're utilizing multidisciplinary team members to help better inform our patients to address safety and efficacy of different therapies available and to sort of treat the whole patient sitting before us?
What we've done here at Duke, and I think many other centers as well, is we've hosted a multidisciplinary tumor board once a week where we bring all of our patients with CNS metastasis, including brain and spine or leptomeningeal disease, to a forum that includes a highly multidisciplinary team: medical oncology, radiation oncology, neurosurgery, and the fourth pillar of that team is palliative care. Whether or not that is symptom management, goals of care, or even end-of-life care. But I found that that's been a very integral way to ensure that all parties are informed of what the other specialty is planning. And many times those conversations might include sequencing of therapies, whether or not it's local therapy followed by systemic therapy. We'll talk a lot about some of the intracranial response rates we've seen in HER2-positive agents in the modern era. We're actually, I think really unprecedented. The medical oncologists are sometimes asked to go first. Sometimes neurosurgical resection is needed. And then also keeping the patient's voice and perspective, where they're coming from in the time that they've been diagnosed with metastatic disease, what other stressors they have outside of the clinic, and their preferences are so critically important to make these decisions as a multidisciplinary team.
Thank you. That was so well said. So I'm going to close this module now, and we'll move into the next session. We're now going to discuss how the sequence is key in HER2-positive metastatic breast cancer, going through evidence, guidelines, and clinical factors to optimize treatment selection and patient outcomes. In 2012 or so, the results from this clinical trial, Cleopatra, phase 3 clinical trial, established the standard of care that remains today in 2025 for the treatment of frontline HER2-positive metastatic breast cancer. In this study, it was established that the use of dual HER2-targeted therapy with trastuzumab and pertuzumab, when combined with docetaxel, led to a significant improvement in not only progression-free survival, but also in overall survival compared to just using trastuzumab with docetaxel. These benefits with the use of pertuzumab, the dual HER2-targeted approach, really stood the test of time. They were long-term. The median overall survival for a patient treated with this THP regimen was close to 5 years. And these were quite practice-changing results that really haven't been challenged or replaced in that time. And that may change in the near future. We shall see. This study recently was presented at the San Antonio Breast Cancer Symposium. And this study, called PATINA, was looking at the use of a CDK4/6 inhibitor in addition to trastuzumab and pertuzumab during the maintenance phase of treatment. So in the Cleopatra study, the THP regimen, patients received 4 to 6 cycles of the chemotherapy taxane component, and then they go on and receive just the HER2-targeted antibodies until disease progression. During that maintenance phase, patients are feeling pretty good, and as standard of care, if their disease co-expresses the hormone receptor, endocrine therapy can be added. So a question came up, does adding a CDK4/6 inhibitor to those patients' treatment regimen in the maintenance setting benefit patients with hormone receptor co-expression, given the benefits we've seen with hormone receptor positive HER2-negative metastatic breast cancer with the use of CDK4/6 inhibitors? In this study, patients were treated prior to being screened for the trial with induction chemotherapy plus HP. And if they had no disease progression, so if they did well with those 4 to 6 cycles of therapy, then they were randomly assigned to receive palbociclib with maintenance HP and endocrine therapy, or just the maintenance HP and endocrine therapy. These results were actually quite interesting, presented at San Antonio, showing a substantially improved progression-free survival by adding that oral CDK4/6 inhibitor to maintenance therapy and endocrine therapy. And I would call out how the median progression-free survival was performing in both of the treatment arms was pretty impressive, 44 months for the palbociclib arm compared to 29 months for the control arm. And so it's important to note that patients were randomized after they had done well on the induction chemotherapy portion. So these are the better behaving patients, if you will, who are enrolled in this trial. All that said, these data were quite interesting, and some would think they were even practice changing. This is not yet approved by the FDA, and as far as I'm aware, is not yet part of our treatment guidelines, but may be part of our treatment guidelines in the future. Now, in recent years, since 2019, we've heard of this antibody-drug conjugate, trastuzumab deruxtecan, which is a HER2-targeted ADC with a cytotoxic payload that poisons topoisomerase 1. This is approved and available for HER2-positive metastatic breast cancer. And in recent years, we've seen it move up into earlier and earlier line settings. And in fact, in the DESTINY-Breast09 study, we may see this regimen replace the THP regimen. Carrie, why don't you take us through the data leading up to T-DXd becoming a standard of care for us, and later we can talk about where it might land.
Sure, Sarah. Thank you for that nice introduction to our current first-line standard of care, as well as the description of trastuzumab deruxtecan, the antibody-drug conjugate. The DESTINY-Breast03 study was practice-changing as it really defined our second-line standard of care in the setting of metastatic HER2-positive breast cancer. And you'll see the design here. This was a randomized open-label multicenter study, effectively enrolling patients who had already received trastuzumab and a taxane in the advanced setting or within 6 months of neoadjuvant or adjuvant therapy to receive the antibody-drug conjugate trastuzumab deruxtecan versus, at that time, the standard of care trastuzumab emtansine or T-DM1. The primary endpoint of this study was progression-free survival. Overall survival was also evaluated. And here you can see very impressive separations of the curve, really unprecedented in the field, where the progression-free survival for trastuzumab deruxtecan was 28 months versus 6 months for T-DM1. And you can also see separation in the curve for overall survival, although not yet reached, but statistically significant with a hazard ratio of 0.64. In addition, the response rate to trastuzumab deruxtecan was quite impressive at nearly 70%, nearly 80%, with 12% complete responses in the trastuzumab deruxtecan arm compared to the T-DM1 arm, with about a 36% overall response rate and a 4% complete response rate. And here again, you can see the updated results, very consistent for the DESTINY-Breast03 study, really defining trastuzumab deruxtecan as our preferred second-line agent. Here are the updated survival results with 52 months favoring T-DXd over T-DM1 at 42 months. So really amazing data here. In terms of what to expect from an adverse event profile, in clinical practice, the adverse events associated with T-DXd in my own practice have largely been fatigue, myelosuppression, and nausea. I would say those are the main issues that I work with my patients on a day-to-day basis. It is a little more challenging to manage, but it is manageable with best supportive care compared to TDM1, where you can see effectively elevation in LFTs and platelet thrombocytopenia, platelet decline are the main side effects there. The other thing to be aware of with trastuzumab deruxtecan is the emergence of interstitial lung disease or pneumonitis. And in the current era, I believe we're doing a much better job in recognizing interstitial lung disease or ILD and pneumonitis in the earlier grade setting. In the initial studies, when we weren't screening or were as aware of this consequence of T-DXd, unfortunately, some of the grades of pneumonitis were much higher, grade 3 through 5. Here you can see for T-DXd in the Destiny Breast 03 study, where we're doing much more extensive screening with CT scans. The majority of the events are grade 1 and grade 2. That's 15% for the T-DXd arm and 3% for the TDM1 arm. So something to be aware of. The management largely includes early intervention with steroids in the grade 1 space, and in the grade 2 space, of course, steroids. But at that point, we do permanently discontinue trastuzumab deruxtecan. So in terms of additional data for trastuzumab deruxtecan, the Destiny Breast 02 study has also been reported. This included patients who had previously been treated with TDM1 and were then randomized in a 2-to-1 fashion to trastuzumab deruxtecan versus physician's choice. And here the two options were a trastuzumab capecitabine combination versus the first generation tyrosine kinase inhibitor lapatinib with capecitabine. And here you can see that T-DXd is the clear winner compared to physician's choice of capecitabine with trastuzumab or lapatinib, both from a progression-free and an overall survival perspective. Now, again, lapatinib is the first-generation tyrosine kinase inhibitor, and I'm going to turn back over to Dr. Hurvitz to talk through the next generation of tyrosine kinase inhibitors and some of the biology of HER2.
Thank you so much, Carrie. That was a great overview of T-DXd and where it's positioned right now. And we will see in a year or so from now whether or not it replaces the THP regimen. But another important therapy, as you highlighted, are the tyrosine kinase inhibitors. Tucatinib is unique in its HER2 selectivity, which is which assists with reducing the side effect of diarrhea because there's less EGFR inhibition. After lapatinib and neratinib, we had the development of a HER2 selective tyrosine kinase inhibitor, tucatinib. The hope and promise of tucatinib was that it would mitigate the risk of diarrhea that comes with EGFR inhibition. And there was also preclinical data suggesting that tucatinib was able to cross the blood-brain barrier and improve outcomes in those patients with brain metastases. The clinical trial that led to the actual approval of tucatinib was the HER2-CLIMB study. This was a placebo-controlled randomized trial looking at tucatinib when added to trastuzumab and capecitabine in patients with HER2-positive metastatic breast cancer who'd previously received treatment with trastuzumab, pertuzumab, and TDM1. This was a very uniquely designed clinical trial because the study proactively allowed patients who had brain metastases, including stable previously treated brain metastases, but also new untreated brain metastases or progressing brain metastases after local therapy. This was a revolution, and actually nearly 50% of patients enrolled in the study did have some form of brain metastases. I'd like to ask Vaishak to comment on this a little bit because this was really a trailblazing study design, and wanted to hear from you about how common it is for you to see this, for this type of study design to be employed in disease histologies outside of breast cancer, and how you viewed this type of study design.
I totally agree with you, Sarah. This was a revolutionary design. Prior to this, patients with brain metastasis were often excluded from these pivotal phase 3 studies or registration trials, and we would have to rely on post-hoc analysis or subgroup analysis to really figure out if there is CNS activities with these agents. FDA and patient advocacy groups have been working towards including more patients with brain metastasis, but brain metastasis can be really challenging. There are heterogeneity in terms of brain metastasis. Some would have, as you said, untreated, some would have local treatment, some would have symptomatic, some would have asymptomatic brain metastasis. How do you follow them? How do you treat them if they develop new brain metastasis during the disease course? All those things were addressed in this study, and this study has become the way forward for other studies in other disease groups, like in osimertinib in lung cancer, KRAS agents in lung cancer, and also in metastatic melanoma. So this is our framework going forward. So this was really revolutionary.
Thank you. Yes, the HER2-CLIMB study did demonstrate that adding tucatinib to capecitabine and trastuzumab not only improved progression-free survival, but also significantly improved overall survival. And this is for patients both with and without brain metastases. We'll talk about the outcomes in a little bit for those patients with brain metastases. Another clinical trial that was conducted looking at tucatinib was the HER2-CLIMB-02 study, looking at adding tucatinib to T-DM1. At the time of this study design, T-DM1 was the standard of care treatment in the second-line setting after trastuzumab and a taxane-based therapy. T-DXd was not yet available. So this study didn't actually look at tucatinib plus T-DXd or use of this dual regimen in patients after T-DXd. That said, it did similarly employ a design that allowed patients who had active, untreated, or progressive brain metastases, and roughly half of patients did in this clinical trial. The study met its primary endpoint by showing an improved progression-free survival by adding tucatinib to T-DM1. However, it's notable that toxicity was increased with the combination therapy. There was about a 16% rate of grade 3 transaminase elevation that seemed to be reversible. But this is something that's important to highlight, and it's also important to note that this is not an FDA-approved regimen or a regimen approved by any of our guidelines yet. The overall survival data are still immature and have not yet shown an improvement in outcomes in terms of survival. There is also some real-world data that I think is helpful to informing our practice. Carrie, do you want to take us through some of these data?
Thanks, Sarah. Yes. So this is a really fascinating real-world data experience across several different databases. You'll see here Flatiron, Komodo, and MarketScan that I had the privilege to work with Peter Kaufman on in concert with industry partners. And the bottom line is what we saw from the clinical trials was really recapitulated in the real-world setting. I think we always worry that what we're seeing in clinical trials may not be applicable or translatable to our real world experiences in the clinic. But what we effectively saw was that, with the tucatinib-based therapies, we saw efficacy across multiple databases, which was very similar to the HER2-CLIMB data. And we also saw a glimpse of similar activity after T-DXd that you referenced. We have very little data currently for the sequencing strategy. Moving on to the next tyrosine kinase inhibitor is neratinib. Again, as you described, Sarah, lapatinib and neratinib both have activity against HER1 and HER2. This can help with binding to the receptors, but can also translate to more toxicity. Interestingly, neratinib is an irreversible tyrosine kinase inhibitor to HER1 and HER2, and was studied in the NALA phase 3 study in combination with capecitabine versus lapatinib and capecitabine. And here you can see a improvement in progression-free survival that was statistically significant, favoring neratinib at 8.8 months versus 6.6 months for lapatinib, with a non-significant numerical improvement in survival by approximately 2 months. We do see with the neratinib and capecitabine combination significant grade 3 diarrhea that can be tempered by some very nice prophylactic strategies with Imodium, dose escalation, and budesonide. So kind of moving forward and taking all of this data into the totality, it's really important to put it into the context of how we're treating our patients in the clinic. And this is a really nice schematic that outlines our current first line, second line, and third line choices for the care of our patients with HER2-positive metastatic breast cancer. As Sarah described, the Cleopatra regimen today remains our first-line standard of care, which includes a taxane with trastuzumab and pertuzumab. In the second-line setting, in the absence of brain metastasis, most guidelines would lean toward trastuzumab deruxtecan based on the DESTINY-Breast03 study. And in the setting of brain metastasis, there could be consideration of either the HER2-CLIMB regimen or trastuzumab deruxtecan, and that is endorsed by the ASCO HER2-positive breast cancer brain metastasis guidelines. Moving into third line, we do have the HER2-CLIMB regimen. Depending on which agent the patient received in the second line, you could also do trastuzumab deruxtecan. But historically, from what I'm seeing in practice, that's largely second line. I'd love to hear from Dr. Hurvitz shortly. And then in terms of the T-DM1 compound, we do have that option largely in third, fourth line and beyond. And this is where we would also start sequencing in other HER2 tyrosine kinase inhibitors. So moving forward into fourth line, and then I look forward to discussion with my colleagues. Again, we do have the T-DM1 antibody drug conjugate, as well as a HER2-directed therapy, margetuximab, we haven't really touched on yet. But briefly, margetuximab is a trastuzumab moiety with an engineered FC component of the receptor to attract immune cells. So it's really exacerbating the antibody-dependent cellular cytotoxicity, or ADCC, that we see with standard trastuzumab. And in the SOPHIA study, was shown to be in combination with physician's choice chemotherapy to translate to improved efficacy over trastuzumab and chemotherapy alone. And then again, we've reviewed the NALA data for neratinib and capecitabine. And then later line, we could consider trastuzumab with chemotherapies. You can see partner chemotherapies here that we largely use in HER2-negative breast cancer, as well as trastuzumab and lapatinib. Here, interestingly, with a non-chemotherapeutic antibody with tyrosine kinase inhibitor strategy. And then just a brief note, special consideration for patients who have hormone receptor positive, HER2 positive breast cancer, you can integrate in fulvestrant, abemaciclib, and trastuzumab based on the Monarch HER data. So a lot of options, a lot of ways to sequence. Dr. Hurvitz, would you like to give us your perspective on this sequencing?
Yeah, I think you did a wonderful job, Dr. Anders, in terms of taking us through. I think this is an evolving area very rapidly. It'll be interesting to see how the DESTINY-Breast09 study reports out. I would anticipate, based on the incredible activity we saw with DB03, that T-DXd will show a better progression-free survival and potentially better overall survival compared to THP, but it'll beg the question of how long do we treat with T-DXd? As I mentioned with THP, you have this opportunity to drop the chemo component after 4 to 6 cycles and just do maintenance therapy. Some patients will derive benefit from that for years and years. And T-DXd has many more types of chemo type side effects. And so selecting which patients need to continue on it is going to be a question for the future. But I agree. I think where it becomes a little dicey, and we're going to need the input from our colleague, Dr. Veneur, is when we have a patient who has brain metastases, how does that second line regimen get shifted? And are we still using T-DXd there? Or are we choosing a tucatinib-based regimen? I thought we could finish this part of the discussion by going over a case and maybe taking a few viewpoints on it, including Dr. Veneur. So we have a 71-year-old woman who has newly diagnosed breast cancer that's hormone receptor positive, HER2 positive 4 years ago. And after surgery, she was lost to follow-up, but then presented 4 years later with upper quadrant pain and fatigue. Imaging did show liver metastases and multiple solid metastases. She had elevated liver enzymes, undergoes a biopsy, and it's ER/PR positive, HER2 positive, high-grade breast cancer. Now, she did not have baseline brain metastases, but I'd like to just hear from Dr. Veneur, maybe just for one quick comment here. Are you recommending we image, and we can get into this more in the next section, but image a patient who's asymptomatic when they're first diagnosed with HER2 positive metastatic breast cancer? Should we be imaging their brain?
That's a very good question without a straightforward answer. There are really no good trials to suggest one way or the other. There are studies that are in progress looking at MRI imaging for these patients with metastatic breast cancer without any neurologic symptoms. What I would say is for patients with neurologic symptoms, you should definitely get brain imaging wherever they are in their disease course, given the high incidence of brain metastasis, especially in HER2-positive breast cancer patients. But for asymptomatic patients, should we get brain MRI depends on a lot of factors. Access to brain MRI, the right imaging modality. There are several sequences that you could get in brain MRI. Is the post-contrast sequence the most important sequence? Is FLAIR imaging the most important? There are so many nuances to it that as a general practice, getting brain MRI on all these patients would incur cost and yet to be defined benefit. So that's the caution that I would add is, what if you find a small lesion which may or may not be brain metastasis? How are you going to manage that? And could it cause more anxiety to patients? Are all things that you want to consider before getting an MRI.
Perfectly stated. Thank you for that. So she initiates therapy with frontline THP, a la Cleopatra. And after 2 cycles, she's much better. After 4 cycles, she has about a 70% improvement in her tumor burden. And after 6 cycles, her liver has a complete response. She is, however, developing moderate neuropathy and edema with the taxane. So she drops the taxane, continues maintenance HP, and starts an aromatase inhibitor with HP. But just over a year and a half later, she experiences progression in the liver with a new metastasis, as well as lung metastases. And so, Harry, how do you approach a patient like this? Now she's experienced disease progression on THP, and she's during the maintenance HP aromatase inhibitor.
No, absolutely. And I think it is important to note that relatively substantial disease control period where the patient was maintained on dual antibody therapy with aromatase inhibition. But we are starting to see at this point resistance mechanisms at play. There are clearly new lesions in the liver. We now have pulmonary disease. So I would be starting to think about and recommending second-line treatment with trastuzumab deruxtecan. I think the question then would be, again, back to Dr. Veneur, do you image the brain? And in this current case, the patient is not presenting with neurologic symptoms. I would be discussing, concern for headache, nausea, word-finding difficulty, handwriting changes. Is there any reason to suspect that with extracranial progression, the patient is also experiencing an intracranial progression event? But I agree completely, Dr. Veneur, until we have more data indicating that we're going to help our patients by obtaining brain MRIs in an asymptomatic state, I'd probably move forward with T-DXd without brain imaging.
I would just be curious that now that we are picking second-line agents based on CNS penetration, would there be more role to look at central nervous system disease? Because it seems like till we get more data, the way we are picking these, the two agents in second-line setting is really based on CNS activity and CNS disease.
Oh, and I think that's a fabulous segue to our final module discussing CNS metastases. So let's move on to the next module. In this module, we'll discuss meeting the challenges of brain metastases with HER2-targeting therapies, providing guidance on modern sequencing and multidisciplinary care to reinforce therapeutic resilience. For the first part, I'd like to ask my colleague, Dr. Vanur, to take us through the differing treatment guidelines that we have right now in terms of the question of whether or not we should be screening asymptomatic patients for brain metastases. Can you provide some of your insights and thoughts here?
Yeah, there is no concordance between various societies on should we screen patients with asymptomatic patients with metastatic breast cancer, especially HER2-positive breast cancer. The ASCO guidelines suggest that there is insufficient data for them to recommend for or against performing MRI scans for screening for patients without symptoms, whereas ESMO says that screening at diagnosis could potentially be justified for patients with HER2-positive and triple-negative metastatic breast cancer. They recognize that this approach could mean a higher rate of detection of asymptomatic brain metastasis. There are several other studies that are in the pipeline looking at screening for brain metastasis in HER2-positive and other advanced metastatic breast cancer patients. Again, these are academic medical centers doing these studies, so there could be some challenges in widely adopting these studies going forward. One of the other things that we should discuss about is identifying and classifying patients with brain metastasis. Historically, we have discussed about neurologic symptoms as indicative of brain metastasis. We talked about some of the symptoms in the previous module, like seizures, focal neurologic deficits, things like speech and changes in speech and cognition, which are more obvious for patients and families. But sometimes a small seizure event could be missed and may have implications for a big full-blown seizure. So all these symptoms have to be viewed in the perspective of how severe they are and how life-changing they are. Symptoms tend to distinguish these brain metastases into patients having active brain metastasis and inactive brain metastasis. But here's where input from radiation oncology, input from neuro-oncology, and neurosurgeons might be valuable in clearly defining symptomatic and asymptomatic brain metastasis. In terms of local therapies, there are two major modalities of treatment that we consider. Surgery is limited to patients with fewer lesions, or if there is a large lesion causing symptoms that could benefit from a surgical intervention where the mass effect could be taken care of. A lot of times, pathology is an important part of diagnosis, so getting a pathologic diagnosis is important by doing surgical resection. There's also a small subgroup of population where there could be a switch in the hormone receptor or HER2 status that could be picked up in these surgical samples. That could be another impetus for doing surgery. In terms of local therapy, there are two main radiation modalities that we want to consider: stereotactic radiosurgery or whole brain radiation therapy. Our field is moving away from whole brain radiation therapy. To be honest, in our clinic, we have single-digit number of patients getting whole brain radiation therapy at any given time, at any given year, which is a huge improvement, say, from, 10 years ago, where we were doing whole brain radiation almost on all patients. Stereotactic radiosurgery is the way to go. It says up to 10 lesions, but there is data to suggest more than 15 lesions, 20 lesions could be treated safely with stereotactic radiosurgery, whether that is one fraction stereotactic radiosurgery or hypofractionated stereotactic radiosurgery. That has become our standard going forward. I would invite Dr. Anders to talk about systemic therapy options for patients with brain metastasis.
I wanted to present here the NCCN guidelines for breast cancer brain metastasis, which you can see are largely divided into HER2 positive and HER2 nonspecific, or largely HER2 negative breast cancer brain metastasis. And effectively, you can see that the therapeutic options for our patients with HER2 positive breast cancer brain metastasis are largely broken up into antibody drug conjugates, such as trastuzumab deruxtecan and T-DM1, or the tyrosine kinase inhibitors, either the selective HER2 tyrosine kinase inhibitor tucatinib, as well as lapatinib and neratinib, both which target HER1 and HER2. So focusing in on the tyrosine kinase inhibitors, the HER2 CLIMB study evaluated the brain-permeable HER2 selective tyrosine kinase inhibitor tucatinib with trastuzumab and capecitabine versus placebo trastuzumab and capecitabine. And this was effectively studied in the third-line setting. What was really unique about this study was the inclusion of patients with brain metastasis. And the inclusion criteria was really unprecedented and has really set the stage, as we discussed earlier with Dr. Veneer, on how clinical trials for patients at high risk of brain metastasis are being conducted moving forward. And you can see here for patients with and without brain metastasis, progression-free survival hazard ratio was 0.5. And interestingly, for the 48% or half of patients enrolled in this study, the PFS hazard ratio was 0.48 for those with brain metastasis. Here you can see the overall survival benefit for those patients with brain metastasis on the left. This included those with asymptomatic and symptomatic brain metastasis. And then interestingly, there was an even larger separation of the curve for patients with active brain metastasis, really illustrating the capacity of tucatinib to make a clinically meaningful difference in patients' outcome with the combination triplet therapy inclusive of tucatinib. In addition, we also saw a substantial improvement in CNS objective response rate. Dr. Veneer did a wonderful job describing the symptoms we see amongst our patients with brain metastasis. So getting that response to decrease symptom burden is really important. And here you can see for the triplet therapy with tucatinib, the intracranial overall response rate was 47% versus 20% for capecitabine, trastuzumab, and placebo. In addition, this translated to a prolongation of CNS progression-free survival favoring tucatinib, which also was impacted by the capacity to incorporate both dual HER2-targeted therapy with the tyrosine kinase inhibitor, the intracellular domain, as well as the extracellular domain with the trastuzumab antibody. In addition, and we've talked a lot about the antibody drug conjugate trastuzumab deruxtecan in an earlier module, but we've also seen, surprisingly, I think if you had asked us years ago, would you imagine a large, bulky antibody drug conjugate would have impact in the CNS? We might have hypothesized no, but in fact, we've seen the exact opposite. We've seen a really substantial improvement in overall response, CNS overall response to trastuzumab deruxtecan. And this is a combination of data, including the Tuxedo study, the Deborah study, and the Rosette BM study, where you can see a range of overall response rate in the brain from 44 to up to 73%. So I'm going to turn it over to Dr. Hurvitz here to talk about the pooled analysis of Destiny Breast 1, 2, and 3, which really hones in on the activity of trastuzumab deruxtecan in the setting of HER2-positive brain metastasis.
Thank you so much, Dr. Anders. Yes, this was an interesting analysis that was done because when the tucatinib HER2-Klein data came out, it became evident that systemic therapy was going to be a really important component of treatment for patients with brain metastases. But the T-DXd agent hadn't been involved in a clinical trial design that prospectively randomized patients who had CNS brain metastases that were active. That said, many of the studies that were done with T-DXd did have patients or did allow patients who had asymptomatic brain metastases that were stable or previously treated. And so what was done was a pooled analysis looking at patients enrolled in the phase 2 single-arm DESTINY-Breast01 study, which is heavily pretreated patients who had previously received TDM1, and all of them received T-DXd. This is the study that led to the accelerated approval of T-DXd. And then the DESTINY-Breast02 and 03 clinical trials we talked about earlier, looking at T-DXd in metastatic HER2-positive breast cancer in the context of a randomized controlled trial. And so looking at the patients enrolled in each of these studies who had brain metastases, most of which were asymptomatic and previously treated, looking at their outcomes compared to outcomes observed in the comparator arms of the other clinical trials. What was interesting was that when you looked at the intracranial objective response rate in those patients treated with T-DXd who had a history of brain metastases, the objective response rate was around 45%. And that was the same regardless of whether patients had treated and stable brain metastases or untreated and active brain metastases. And if you look at the comparator pool, those patients who received a comparison treatment of TDM1 or the other comparison arm of trastuzumab or lapatinib plus capecitabine, it looks like the objective response rate associated was lower in the brain with these agents. Now, of course, all the caveats go along. The study didn't randomly assign patients. It didn't allow active symptomatic brain metastases. But this sort of subgroup analysis from an exploratory standpoint was very reassuring that T-DXd is having benefit in patients with brain metastases. If you look at the CNS progression-free survival on the left for those with treated and stable brain metastases, and on the right for those with untreated and active brain metastases, patients seem to be doing better if they were randomized to receive T-DXd compared to the comparative arm. Now, a prospective study was not randomized, but still a prospective study that's added to evidence for these patients was recently presented at ESMO in 2024, the DESTINY-Breast12 clinical trial. In this study, patients were allowed, if they had a HER2-positive metastatic breast cancer, either with or without brain metastases, and they were enrolled into the cohort based on the presence of brain metastases. There were 263 patients who had baseline brain metastases that were either stable or active, and they were treated with T-DXd and followed for outcomes. The study showed in the patients with baseline brain metastases, the progression-free survival median was about 17.3 months. And this is a fairly heavily pretreated patient population. The patients with active brain metastases, their 12-month progression-free survival, if they had never had treatment for the brain mets, was a little bit lower than patients who'd had previous treatment. But overall, outcomes seemed to be fairly decent, even in those patients with brain metastases. Looking at the CNS progression-free survival, again, it looked very similar for patients in the overall population and in patients who had stable versus active brain metastases. The intracranial objective response rate for patients in this study was also very impressive, in my opinion. You're seeing over 60% of patients in general having an intracranial objective response with the use of T-DXd. If you're looking at those who had untreated active brain metastases, 82% of them are having a response intracranially, and if you compare that to patients who previously had treatment, about 50% are having an intracranial objective response. Overall, I think these data provided a lot of reassurance that T-DXd does have activity in patients who have HER2-positive brain metastases. I think another exciting area is looking at combining antibody-drug conjugates with small molecule tyrosine kinase inhibitors. Dr. Andrews, do you want to take us through the HER2-CLIMB-02 data as well as other studies looking at novel combinations?
Sure, I'd be happy to. What you're seeing here is the schema for the HER2-CLIMB-02 study. And the question that was to be answered by this study is, does the addition of the brain-permeable TKI, HER2-targeted TKI tucatinib add to the activity of TDM1? Here you can see that patients with a history of brain metastasis were allowed in this study, again, really showing the progression and the inclusion of patients with brain metastasis in more recent clinical trials. Here you can see, based on HER2-CLIMB-02, the tucatinib did prolong progression-free survival when added to TDM1. On the left-hand side, you'll see the intention to treat population. But what's really interesting is the brain metastasis subset, where you see that patients with brain metastasis had a progression-free survival of 7.8 months for the combination of the antibody-drug conjugate with tucatinib versus TDM1 alone. There are many other examples of tyrosine kinase inhibitors and antibody-drug conjugates. Just to name a few here, to highlight a few, with neratinib, either in combination with capecitabine. There's also an arm of TBCRC-022 that evaluates the combination of neratinib and TDM1. In addition, there are ongoing clinical trials in the setting of metastatic HER2-positive breast cancer with brain metastasis and emphasis that we should keep on our radar. The first one you'll see here on the left is the HER2-CLIMB-05 study, and this is evaluating the addition of tucatinib to maintenance trastuzumab-pertuzumab after induction therapy with a taxane versus placebo trastuzumab-pertuzumab. One would hypothesize, although we need to see the data, that the inclusion of a HER2 tyrosine kinase inhibitor that's brain permeable would be advantageous for our patients with brain metastasis and potentially even prevent brain metastasis, which would be the ultimate goal. On the right-hand side of the slide, you see the study that Dr. Hurvitz referenced earlier, the DESTINY-Breast09 study. And this is really challenging the Cleopatra regimen that has been tried and true for nearly a decade or over. So a lot to look forward to in the setting of metastatic breast cancer with and without brain metastasis. So Dr. Hurvitz, I'll turn back over to you to discuss the interesting concept of multidisciplinary care for our patients with brain metastasis.
Thank you so much. So that was fabulous. And I think that this discussion in terms of multidisciplinary care and the role not only of our radiation oncology colleagues and surgeons who are critical, now more and more medical oncologists are being involved in the discussion and decisions regarding the management of brain metastases. But we have this burgeoning field of neuro-oncology that is also getting involved in management of brain metastases, not just primary brain tumors. So I don't know, Dr. Vannour, maybe you can take us through the role as you see it of your field and how we should capitalize on the knowledge and expertise that your field brings.
Thank you, Dr. Hurvitz. That is true, that it takes a village to decide on what to do for these patients, which is a good thing in the sense that there are more therapeutic strategies for these patients, but it's also important to make sure that we care for adverse effects and their future course of treatment as we decide on the current treatment strategies. For example, this slide lays out some of the things that we think of when we're thinking of local strategies versus systemic therapies. And this really needs a team of medical oncologists, radiation oncologists, neurosurgeons, neuroradiologists, pathologists, neuro-oncologists to kind of sit at the table potentially a tumor board or some forum to really go through all these factors and figure out how to best approach this patient. At our clinic, this happens almost daily. I have a radiation oncologist who sits with me. We have all sorts of communication with our breast oncology colleagues to come up with a strategy. Some of the things, as we had mentioned in the past, that we think of when we are thinking of local strategies is, say, for example, CNS is the only site of disease. That would be a good time to think of local strategies. We talked about neurologic symptoms. We talked about large lesions, although there's no definition for large lesions. I would think of large lesions as lesions that could not be treated with SRS safely as large lesions. Bad localization, for example, cerebellar lesions or lesions that are going to cause obstructive hydrocephalus would be lesions that you would want to get local therapy first. If the swelling is causing a lot of symptoms, you want to consider local therapy first. But if there are very asymptomatic, often tiny brain metastases, then considering systemic therapy makes a lot of sense. And that is where a bulk of our patients are at this point, is they have asymptomatic tiny brain metastasis at diagnosis. And those patients probably would benefit actually from systemic therapy and delaying local therapy. And who decides on that, how do we decide on that, is the way forward with this kind of multidisciplinary discussion. And patients need to be part of this discussion. I think patients need to learn from various different sources to engage with us as care team. And one of them is mbcbrainmets.org that has really good resources for patients to learn about CNS metastasis, survivorship from CNS metastasis and treatment, and what are the new novel clinical trials going forward for patients with brain metastasis. I'll hand over to Dr. Hurwitz again to talk about a case.
Yes, absolutely. Thank you. That was wonderful. And, we do have our patient, we discussed in our first module, a 71-year-old woman who has metastatic ER-positive, HER2-positive breast cancer, symptomatic and involving the liver. And let's just assume that she had some neurologic symptoms that were concerning, and that led to brain imaging that revealed a single 2-centimeter brain metastasis. And so I'd like to ask each of you sort of what would your approach be here? First, Dr. Anders, if you could take us through sort of managing frontline somebody who has both extracranial disease as well as intracranial disease.
This is an all too common scenario in our clinics. And I think that the challenge with this case is the fact that the patient does have elevated liver function. So we are starting to see some organ dysfunction in the setting of metastatic disease, which means that we would like for that patient to move forward with systemic therapy sooner than later. In a perfect world, we would want to have tissue from the CNS. But in this scenario, given the fact that we do have liver metastases, it would be very reasonable to have the liver metastases metastatic biopsy help us with the receptors for the recurrence, which we see here remains ER positive and HER2 positive. So I would be having a very balanced conversation with our radiation oncologist about, first of all, neurosurgery should be involved just to ensure that the brain metastasis is not in a precarious location or placing the patient at risk. And then I would be having a very balanced conversation with our radiation oncologist regarding who should go first. Is this a case where the radiation oncologist would feel comfortable with the systemic therapy being the first line of therapy, or could we have a short period of time where radiosurgery could be administered and then follow with systemic therapy? So I see Dr. Vannour shaking his head, and I'm curious. I'm waiting with bated breath as to what your thoughts would be.
I would totally concur with you. That's the kind of discussion I would have with the patient and with the treating team. This is a solitary lesion. Yes, in an ideal world, neurosurgeon potentially could go in and take this out. But what are we going to gain by doing that? That would mean we would want to wait till wound healing, which generally is about 2 weeks from the time of surgery to start any kind of systemic agents. And clearly here, liver organ dysfunction is really pressing. And that shows that there's uncontrolled systemic extracranial disease that needs urgent systemic therapy. So a lot of times I would yes, get neurosurgery involved, or I would weigh in and say, hey, look, in this scenario, neurosurgery is probably not important. What's important is probably to bridge them with seizure management if that was the symptom, or steroids if that was the presenting symptom was because of the swelling, and consider one fraction stereotactic radiosurgery, which could be done very quickly and go on to systemic therapy. The goal would be obviously to control the liver disease, but also prevent future brain metastasis. That would be the approach I would take. Obviously, a lot of discussion and caveats that go into that decision.
Yeah, those are great points. Really, really good points. I'm interested, Carrie, you have a multidisciplinary analysis or tumor board, I think, with patients who have brain metastases, if I'm not incorrect. And so how do you present the options to the patients so that they're part of that decision making? Is it sort of risks benefits? Do you present multiple options with participation from the various experts, or is it the medical oncologist who's conveying the recommendations of the multidisciplinary team?
Now, that's a great question. And what we've effectively developed at the Duke Center for Brain and Spine Metastasis, as every Tuesday morning at 7 a.m., we have a highly multidisciplinary conference of cases very similar to this. And each of the stakeholders weigh in as to exactly what Dr. Venur was describing. What is placing the patient at most risk? What is the timing of therapy? What modality of therapy should we be thinking about? Should the systemic therapist go first or the local therapist go first? What can we effectively combine together that's not going to place the patient at risk for radiation therapy necrosis for our patients with HER2-positive disease? That is a very real concern, given that we anticipate they will live for years in the modern era. And how can we mitigate side effects from radiation therapy necrosis down the road? So effectively, after the tumor board, we have patients meet with each of the disciplines. We'd prefer for it to be on the same day. Many times it's 2 days in a row. We will have the patient meet with medical oncology, radiation oncology, neurosurgery if indicated. And then we always offer our patients a consult with palliative care to really understand what their symptom management can look like, to process the information, and to discuss goals of care.
Those are amazing points. And I think if you summarize our discussion today, this is becoming a really rapidly evolving area. And these sorts of discussions and treatment decisions are quite nuanced and require that we as providers are kept up to date on the latest and greatest data, and also are equipped to convey that in a patient-focused manner to allow them to share in the decision-making. So I want to thank my colleagues today for an incredibly robust discussion packed with data. It was really fun to hear from you, Dr. Venur. Your perspectives as a neuro-oncologist were really keen and important. And Dr. Anders, of course, your expertise in this area is so much appreciated. Thank you both, and thank you everyone for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, GRASP. This activity is supported by an educational grant from Pfizer. To access all materials for this activity, visit peerview.com/ZPG860.